Hi, I'm Dr. Sho. Today I'll be talking about pharmacokinetics. Because pharmacokinetics is a very wide topic, it will be difficult for me to exhaust the teaching in a single video. Therefore, I'm going to split the teaching into three different parts. So this part, I'll title it Pharmacokinetics Part 1. Now that word pharmacokinetics is derived from two Greek words, pharmakon, meaning drug, and kineticos, which means putting in motion. So, if you want to join those two together, you can say pharmacokinetics is putting drug in motion. Maybe you say it that way, at least it will give you a rough idea of what pharmacokinetics is all about. But strictly speaking, what is pharmacokinetics? Pharmacokinetics is a branch of pharmacology that deals with the study of the movement of drugs in the body. It is the kinetics of drug absorption, distribution, metabolism, and excretion. One way to remember what pharmacokinetics is to say it is what the body does to the drug. So if you put it that way, you now sit back and think, okay, what does the body do to the drug? First, the body will absorb the drug, take the drug into the body. Then, after absorption, the body will move the drug around the body. Then later, the body will break the drug into different smaller units or components, metabolism, and then after some time, the body will get the drug and or its waste product out of the body, excretion. So you can look at it that way, but I don't like students of pharmacology defining pharmacokinetics as what the body does to the drug. I believe that simplified way of viewing pharmacokinetics merely serve to remind us, or should merely serve to remind us of what pharmacokinetics is really about. We know that there are different membranes in the body, and the drugs, once they enter into the body, will have to pass through those membranes. Because of this, it is important that we refresh our memory about the structure of the membranes in the body. However, I'm not going to discuss that here. That will be a topic for another discussion. I think in that discussion, I will focus exclusively on the cell membranes. Nevertheless, we still need to talk about the transport processes that convey the drugs around the body. And for the movement of drugs across the body or across the biologic membranes, there are certain factors that influence this movement. And these factors include the molecular size and shape of the drug, the degree of ionization of the drug, the relative solubility of the ionized and non-ionized forms of the drug, and then the binding of the drug to serum and tissue proteins. The movement of drugs across cell membranes can be by passive mechanisms or can be by active mechanisms. And for passive mechanisms, the two main transport mechanisms that fall under the passive transport are diffusion and filtration. And from our elementary chemistry, we remember that diffusion is the movement of a solute from an area of high concentration to a region of lower concentration. It is the same thing here. Diffusion is movement of drug from an area where the concentration is higher to an area where the concentration is lower. So it is along a concentration gradient. And this is due to its solubility in the lipid bilayer. So the transfer of drugs by diffusion is directly proportional to number one, the magnitude of the concentration gradient across the cell membrane. Number two, the lipid water partition coefficient of the drug. And number three, the surface area of the membrane that is exposed to the drug. Filtration, on the other hand, is passage of drugs through aqueous pores in the membrane or through paracellular spaces. And the rate of filtration is increased when the hydrodynamic flow of the solvent is occurring under hydrostatic or osmotic pressure gradients. For example, this is what happens across most capillaries in the body, including the glomeruli. We should also note that lipid insoluble drugs whose molecular sizes are smaller than the diameter of the pores also cross biological membranes by filtration. The brain is an exception to this because of the blood-brain barrier, which limits the passage of most drugs. However, with inflammation of the meninges, the brain becomes more permeable to drugs that would otherwise not have penetrated. Under the carrier-mediated transport, the first transport mechanism to be discussed there is active transport. And active transport refers to movement of drugs against an electrochemical gradient. Other features of active transport include a requirement for energy, also include its saturability, and also it is selective. And there is competitive inhibition between co-transported substrates. In primary active transport, the energy for the transport of the drugs is obtained directly by the hydrolysis of ATP. And the transporters responsible for this belong to the family of ATP binding cassette transporters, which have ATPase activity. The ABC family only mediate efflux of solute from the cytoplasm, either to extracellular fluid or into an intracellular organelle. And examples are the P glycoprotein, the multidrug resistant protein 2, then the breast cancer multidrug resistant protein. In secondary active transport, the energy to pump one solute is derived from the downhill movement of another solute, mostly sodium ion. And when the concentration gradients are such that both the solutes move in the same direction, the transport is called symport or co-transport. And when the movement is in opposite directions, it is called antiport or exchange transport. Metabolic energy from the hydrolysis of ATP is spent in maintaining high transmembrane electrochemical gradients of the second solute. Then the solute transporters, SLC, mediate both uptake and efflux of drugs and metabolites. Another example of secondary active transport is in the sodium glucose cotransporters 1 and sodium glucose cotransporters 2. In facilitated diffusion, there's no requirement for energy, and movement of the drugs is down an electrochemical gradient. A good example of this form of transport mechanism is the transport of glucose across the muscle membrane by the glucose transporter 4. This transporter belongs to the superfamily of solute carrier transporters. Now, having briefly looked at the transport mechanisms by which drugs move across cell membranes, let's take one or two of the parameters under pharmacokinetics. And the first parameter that we'll examine here is absorption. So what is absorption? Absorption refers to the movement of a drug from its site of administration into the central compartment. Several factors affect the absorption of a drug, and these factors include the aqueous solubility or rate of dissolution of the drug. This is important for drugs that are administered orally. Presence of food in the stomach is also important for drugs that are administered orally, because presence of food in the stomach, the drug might form complexes with the food, which will limit the absorption of the drug. The presence of other drugs in the stomach also can inhibit or can affect the absorption of drugs that are administered orally, because those drugs can form complexes also with the administered drug, and such complexes might be insoluble and will not be absorbed. Example of this is found in case of tetracycline and oral ions, where they can form insoluble complexes with calcium, calcium tablets or calcium preparations, or with antacids. So it's advised that you should give an interval of between 2 to 3 hours between administration of these drugs that I just mentioned. There are other factors too that can affect the absorption of drugs. Surface area is one important factor. The surface area available for absorption of the drug is very important still in cases of orally administered drugs. Blood flow to the area is very, very important. The concentration of the drug is also a very important factor that can influence its absorption. The next parameter to be examined is drug distribution. And drug distribution, when the drug is after absorption, it goes into the blood, but it will not remain within the blood. From there, it will move, it will be distributed. No, it will move. Let me not use that word distributed yet. It will move into the interstitial and intracellular fluids and into the body tissues. So the movement of this drug from the central compartment into the interstitial and intracellular fluid is what is known as distribution. And distribution is influenced by factors like cardiac output, like regional blood flow, capillary permeability, tissue volume, and plasma protein binding. The organs that receive most of the cardiac outputs, like the brain, the heart, the liver, the kidneys will first be exposed to a large concentration of that drug. But gradually, the drug will start getting distributed to less perfused organs until eventually there is equilibrium. One important thing for us to note about distribution is that many drugs are transferred across the placenta. And this is important because the drugs that are transported across the placenta might have effects on the baby. Some can be teratogenic, so it is important that we know the drugs that are safe to use in pregnancy and the ones that should not be prescribed during pregnancy because of the risk of exposure and teratogenic effect on the fetus. An important factor to be considered under distribution is volume of distribution. And this is defined as a theoretical volume that will accommodate all the drug in the body if the concentration of the drug throughout was the same as in plasma. And mathematically, it is depicted as the dose administered divided by the plasma concentration of the drug. Lipid insoluble drugs do not enter cells. Therefore, their volume of distribution approximately equals the extracellular fluid volume. But when the value of V, that is when the volume of distribution is high, a large quantity of drug is present in extravascular tissue. And this is very important in cases of poisoning because drugs with lower volume of distribution means that those drugs are restricted to the intravascular compartment, so they are easier to remove by hemodialysis. But drugs with a high volume of distribution, a lot of them are already inside the tissues, are in areas where hemodialysis will no longer be able to extract them. And because of this, poisoning can be difficult to manage in the cases of poisoning by these drugs. Volume of distribution is affected by conditions like congestive heart failure, uremia, hepatic cirrhosis, and others. One other thing that we need to know about drug distribution is the fact that a lot of drugs in the blood are circulated by plasma proteins. Some are bound by proteins in the blood, while some are bound by proteins in the tissues. So you have plasma protein binding and you have tissue protein binding of drugs. For acidic drugs, the commonest protein that binds them is albumin, whereas alpha-1 acid glycoprotein bind basic drugs. These two, albumin and alpha-1 glycoprotein, are the most important proteins involved in drug binding within the plasma. However, there are other proteins that also bind drugs, that bind particular types of drugs. For example, the sex hormone binding globulin transport the sex hormones, whereas tyrosine binding globulin is responsible for transporting the thyroid hormones. We should also note that drugs can compete with each other for binding to plasma proteins. And this is of clinical importance because if a drug displaces another drug from the binding site, it means the plasma concentration of the displaced drug. It means the free fraction of the displaced drug will become higher. And we should note that drug responses are a function of unbound drugs. The toxicity of drugs, the pharmacologic effect of drugs are manifested by the free or unbound drugs. So if a drug is displaced from its binding site by another drug, that means the free fraction of the displaced drug become higher. Therefore, there could be exaggeration of the pharmacologic and toxic effects of that drug that is displaced. So what are the consequences of plasma protein binding? Number one, highly plasma protein bound drugs are likely restricted to the vascular compartment. Number two, the band fraction is not available for action. Number three, high degree of protein binding generally makes the drug long acting. Number four, the generally expressed plasma concentration of the drug refers to the band as well as free drug. We should also note that one drug can bind to many sites on the albumin molecule. Conversely, more than one drug can bind to the same site. Then, we should also know that in hypoalbuminemia, binding may be reduced and high concentration of free drug may be obtained, just as we mentioned, similar to what we mentioned earlier. Let's quickly look at tissue binding. Drugs can accumulate in tissues at concentrations higher than in the blood and in the extracellular fluid. For example, the anesthetic agent tiopental, repeated uh, doses over a long period of time, it may accumulate in fatty tissues in the body, and then this may prolong the recovery of the patient from the anesthetic state. Then, drugs like tetracycline, like red, like radium, and phosphonates can accumulate in bone, and this lead can be retained in bone for up to 20 years or longer. And in cases like this, it might serve as a source of chronic poisoning for the individual, whereby it will be getting released gradually and slowly into the circulation. We already discussed about placental transfer of drugs. So we should just note that we should be careful with drug administration in pregnancy because the drugs can cause adverse effects on the neonate and it can cause teratogenic effects in the neonate. Thank you.